Good morning. Surgical audit for MR Hospital. Here we have three surgical units who runs OPD for twice a week, and we run our operation theatre for twice a week. Audit will be presented by the unit. Made in charge are Dr. Untitled Chakraborty and Dr. Siddharth Mishra. Dr. Suman will present. Suman, you can share your screen and start presenting.
Good morning, sir. Am I audible, sir? Good morning, sir.
Yes, nicely audible.
Thank you, sir. I am going to present a surgical audit for August 2022. For the unit 1. Hello?
Yes, carry on.
Okay, sir. Me, Dr. Shumon Pal from Unit 1 General Surgery. In summary, the Unit 1 has faced total OPD days in number 8 and total admission days was 10 in number. Total patients with COVID-19 infection was 0 and total OPD patients was 1314. Out of which old patients were 580 and new patients were 734. Total number of elective OT days was faced 9 in number, out of which in table 1 we have spent 26 hours 40 minutes, that is in laparoscopic interventions, and in open interventions we have almost 20 hours 40 minutes we have spent. Total number of minor OT days were 8, out of which we have spent in which almost about 19 hours 45 minutes. And time in emergency OT, we have spent 10 hours 40 minutes, and in the whole time period, we have faced no mortalities at all. Audit for August 2022. As a whole, elective admissions were 35 in number, out of which 21 were male patients and 14 were female patients. Emergency admission were 23 in total, out of which 11 were male and 12 were female. Elective operations, we have done almost 30 in number. 11 were female and 19 were male, out of which. Emergency operations, almost 7 we have done, and 4 out of which 4 were male patients and 3 were female patients. As a whole, minor operations, we have done 35. And there were no mortality and no morbidities at all. Elective, as far as elective admissions are concerned, we, as intervened in hepatobiliary system and pancreatic splenic surgeries, we did chronic, in case of chronic calculous cholecystitis, we did some laparoscopic cholecystectomy that were 10 in number, out of which 3 were male patients and 7 were female patients. One patient was found to be having choledocholithiasis with cholelithiasis. There we went for open CVD exploration and cholecystectomy with repair of CVD over tissue. And that was just 1 in number. And that was a male patient. As far as GIT and perianal cases are concerned, we have done 3 fistulectomy, out of which 3 were male patients, and lateral sphincterotomy in fissure in ano in 2 patients, all of them were male. Laparoscopic appendicectomy was done in recurrent appendicitis. Almost 3 out of which 3 were female patients and 1 was male. As a whole, 4 laparoscopic appendicectomy was done. So as a whole, GIT cases were 9 in total in last month. Next slide, please. As far as hernia and groin surgeries are concerned, mainly umbilical hernia, we did 1 cases. Inguinal hernia were almost most of them. There we did Liechtenstein tension-free mesh hernioplasty, almost 18 number male patients. And incisional ventral hernia, mesh hernioplasty was done. That was 1 female patient. In emergency, we got a patient having sigmoid valvular. It was a male patient and almost 2-year-old was admitted to emergency. He presented with acute intestinal obstruction. There we did re resection followed by colostomy, and few acute appendicitis were admitted also that were 2 in number, and there we did open appendicectomy. Some diabetic foot ulcers were admitted through emergency. Incision and debridement were done, followed by dressing, repeated dressings. Minor operations, we did few wage biopsy from ulcerative lesions, and was only 1 in last month. Excision of sebaceous cyst was done 12 in number, out of which male was predominant, 7 was the number, and lipoexcision was done in 6 in total. Excision and drainage of abscess was done in total 8, and foreign body exploration was under skin exposure, and that was done 4 in number, out of which 3 were male patients. So in total, 35 cases we did. And mortality so far as concerned, it was less encountered in the last month. It was nil basically. So last month was very good for us. Thank you. Thank you, sir.
Shuman, you have presented well, and good number of cases are done. But what I feel is, as resident, mobility assessment is not perfect. You see, you are operated 50 patients almost. So
Yes,
all
sir.
the patient has a perfect recovery is very unusual. You see, any deviation in the posterior period is a morbidity. Patient might have prolonged ileus. Some patient might have a stitch abscess or minor urinary infection. So yeah, the idea of discussing is what is happening to this patient. If my 3 unit says we have 0 morbidity, then it will be impossible to accept. There will be some morbidity for some patient. It can be minor morbidity, and it can be a major. So try to find out the deviations patients have. This has to be noted on day-to-day rounds. At the end of month, if you go, you cannot remember what happened to each of these patients. Okay, emergency patients and elective patients might have some morbidity, and that need to be managed. The idea of presentation is to discuss what was the morbidity and how that was managed. Okay, otherwise you presented very well. We can pass on to the next presentation by Dr. Prasenjit Basu for presentation for Unit 2. Bed in charge are Dr. Jaideep Rai and Dr. Abhishek Bhomik.
Good morning, our respected faculty members and our respected teachers. I am Dr. Prasenjit Basu, presenting the surgical audit for August 2022 for Unit 2. The summary includes total OPD days of 9 and total admission day 11. Total patient with COVID-19 infection nil. Total OPD patient 1175, which includes old 470 and new cases 705. Total number of elective OT days 9. Total time in OTV spent table 1 lab, which includes 36 hours and 30 minutes, and table 2 open 52 hours and 30 minutes. Total number of minor OT days 9, and total number of mortalities includes single case. Sorry, audit August 2022. Sorry, it's by mistake.
Okay.
Elective admission includes 72, which includes male 30 and female 42. Emergency admission 15, which includes 7 male and 8 female. Elective operation 27, which includes 9 male and 18 female. Emergency operation includes 9, which includes 3 male and 6 female. Mortality single case male. Morbidity, sorry, here is also mistake. Morbidity includes three cases total, which includes one and one female. Elective admission in hepatobiliary and pancreatic splenic surgery, coronary calculus cholecystitis, for which we did laparoscopic cholecystectomy for 5 cases, which includes 2 male and 3 female, and open cholecystectomy done in 3 cases, in which includes 1 male and 2 female. And one choledocholithesis is presented, for which CVD exploration done and choledochoduodenostomy with drainage procedure done in single male. Sir, in GIT and perianal cases, fistula in ANO, fistulectomy done for 4 cases, 3 which includes 3 male and 1 female. Fissure in ANO, for which lateral internal sphincterotomy done for 4 cases and 3 male and 1 female. In hernia and groin surgery, incisional and ventral hernia, for which mesh hernioplasty done at retrorectus plane for in female single female cases, and inguinal hernia for which Liechtenstein tension free mesh hernioplasty done 5 cases, 5 male cases. Breast and endocrine, which includes a fibroadenoma in right breast, for which local excision done, and 1 excision of lipoma at intermuscular in posterior aspect of thigh. We did lipo excision for this. For emergency cases, we did which includes acute appendicitis, diabetic ulcer, and peptic ulcer for operation. Open appendicectomy done for acute appendicitis, and diabetic incision and debridement done, and Graham patch repair done for peptic ulcer perforation. For minor operation, we includes which includes wedge biopsy from ulcerative lesion, excision of pyogenic granuloma, lipoma excision, and core needle biopsy, and sebaceous cyst excision. Numbers are morbidity and mortality. Morbidity in 2 cases there is wound infection post-op case. In 1 case, exploratory laparotomy and peptic perforation repair done, in which local collection of pus and in 1 case post appendix open appendicectomy, in which also local wound infection occur, for which in both the cases we manage conservatively. And in single cases, bile leak in a case of post lab cholecystectomy patient in female patient, in which also we did conservative management. Mortality includes single case, a 68-year-old gentleman admitted with features of diabetic foot ulcer with gangrenous changes with thrombosis of lower limb vessels associated with chronic kidney disease, uncontrolled type 2 diabetes mellitus. This patient was admitted from male medicine ward. The patient is on severe septic shock in multi-organ incision and debridement, but later patient developed sudden cardiac arrest and could not be resuscitated. The patient also includes features of thrombosis in aortoiliac region, up to aortoiliac region, and he also received dialysis treatment, single episodes, but we cannot revive it. Thank you.
How did you manage the biliary leak? How much was the leak and how long it persisted? What you did?
Sir, we
What
did
was the biliary leak? How much?
Sir, 100 ml.
100 ml with of day. You said it is conservative. What conservative treatment you did?
So we did sir antibiotic
Conversion.
management,
You're
fluid
testing audit and
management.
then you're putting up. No. What I mean,
Yes, sir.
was it a easy cholecystomy or difficult cholecystectomy? Was it a easy cholecystectomy or difficult cholecystectomy?
Sir, difficult. Is gross adhesion is present in liver, bed, omentum, and duodenal.
So it will be difficult.
Adiosylisis is done.
It will be drain
Adiosylisis is done, and
and pass post of the
HRP drain is placed, sir. And
okay.
biliary contents.
So
Sir.
what happened? What happened to this biliary drain over the period of days? What
Sir,
happened
it
to this biliary
subsequently
drain over days?
reduces, sir. It subsequently reduces the content and amount is gets reduces, and later it become nil, and then we
How many
omitted
days?
POD 7 up to sir. POD 7.
How many days?
Yes, sir.
7. So it took 7 days for this to heal. It took
Yes,
7
sir. Yes,
days.
sir. Yes, sir. Yes, sir.
Of this biliary leak which persists might be the underlying cause for this leak. You have to think about it because next mission 7 days time leak maybe 400, 500. So what do you think this patient might have? What are the possibilities? क्या हो सकता है? If you go by very minor things, it can be a leak from gallbladder bed. If the gallbladder was very deeply placed in the almost intrahepatic gallbladder, in that case, there may be some leakage from the fine radicals in the gallbladder bed. It can be a injured cholecystohepatic duct. He said it was difficult. It may be that cystic duct could not be clipped properly. There is leakage from the cystic duct itself. Or it can be the next most important and common is a bile duct injury. So in subsequent 7 days, maybe it was not a major bile duct injury. But you have to keep this patient under follow-up.
Yes.
And mortality slide, you show the mortality slide. You see, this is not the presentation for mortality slide. We want details chronology. You said patient was in the medicine ward. How long you was in the medicine ward? You took over the patient on which day? When did you do the debridement? When was the dialysis done? What happened afterwards? You see, the idea of analyzing a death case is to understand why the patient has died, whether you could have done some intervention to save the patient. So that this gives us a lesson for the subsequent patient. Okay, so try to analyze the death patient in a chronological way. We don't have postmortem. I cannot give you the 100% cause of death and just history, and you can have some close discussion to find out what is the immediate cause of death and what is chronology of events that lead to death of this patient. Okay? Thank you.
Yes.
Any comment from Dr. Rai? Dr. Rai is there online? Dr. Rai, Dr. Abhishek?
Yes, sir. Yes, sir. Nothing specific, sir, but it could have been presented well. Like you told, the chronology should have been mentioned, and the events they could have been elucidated in more detail so that we could prevent further deaths.
Presentation is by this one of unit our very Dr. Rai myself, but Itmani can present.
তুমি বন্ধ করে দাও। হচ্ছে না কেন? You cannot share screen lecture. তোমার মিলনকে ফোন করো, তোমার ফোনটা তাই ফোন করো।
প্রেজেন্ট করো না, মনে হয় এসে যাবে। मिलेगा वो कितना वाला वो मिलेगा दूसरा स्टार्ट करने बोलो, स्टार्ट करो आज से
কি করে স্টার্ট ইনভিটেশন
বলো, মুখে বলো, ফুল স্টার্ট করো।
হ্যালো
Sir, is the screen visible?
Is visible. Screen is visible.
আমারটা খুলবে কি করে? Good morning. I am Dr. Dismanandi, first year PhD from Unit 3 Surgery. Good morning to my respected mentors, teachers, and dear colleagues. I am going to present the surgical audit for August 22 under Unit 3 General Surgery. In the month of August, there were the number of OPD days were 9, number of total admission days were 10, total number of OPD patients was 1171, of which new cases was about 851 and old cases about 320. Total number of elective OT days was 9. Total number of OT duration in time is about 54 hours 25 minutes. Total number of minor OT days 19. Total number of mortalities 2 and total number of morbidities 3. Now, in the month of August 2022, elective admission was total 61, of which male was 32 and female 29. Emergency admission number is 10, of which male is 6 and female 4. Elective operations about 59, which includes 27 female and 32 males. Emergency operations 2, of which 1 is male, 1 is female. Mortality is 2, of which 1 is male and 1 is female. And morbidity number is 3, which includes 2 males and 1 female. Now against little subdivision about the number of OTs or elective admissions which have occurred in the month of August 2022. Number of chronic calculus cholecystitis cases was managed by laparoscopic cholecystectomy, which was total 10, which includes 4 male cases and 6 female cases. Chronic calculus cholecystitis, which was managed by open cholecystectomy, it includes total 2 cases. Inguinal hernia cases managed by laparoscopic interventions is totally 3. And inguinal hernia cases managed by open hernioplasty is total number of cases is 7. Of which 5 was male and 2 females. Perianal fistula cases managed by fistulectomy, total cases was 3. There was a case of obstructive jaundice, which was managed with open cholecystectomy with CVD exploration with biliary drainage. The number of these cases 1, which was a male patient. Then another case of carcinoma head of pancreas, which undergone triple bypass palliative surgery. Next, there was a case of carcinoma rectosical, which was managed with total D2 colectomy with ilioanal anastomosis with proximal stoma. This is a one case of a male patient, which was a middle-aged male patient. Next is next are anal fissure cases. There was total 2 cases, of which one was male and another female. Recurrent appendicitis managed with laparoscopic appendicectomy. Total number of cases were 3, of which one was male and 2 female. Recurrent appendicitis cases, which was managed with open appendicectomy. These were little about 30-40 years patients. Managed with open appendicectomy. Total number of cases were 3, of which 2 males and 1 female. There was a case of obstructive jaundice managed conservatively. Then there are another case of umbilical hernia given mesh hernioplasty intervention. There were 3 cases of phimosis undergone circumcision operations. Total number of cases were 3. Diabetic foot or gangrenous case was there, which was managed with below knee amputation. This was a single case. There were 2 cases of head injury, which were given conservative management. Then there was a gangrenous leg lesions on the right leg, which undergone some debridement. There are 2 cases. There was one right inguinal abscess, which undergone IND. This was a male patient of a young male patient, about 15 to 16 years of age. Then there was a case of varicose vein, which undergone stripping with phlebectomy. Then there was also a case of parotid abscess, which undergone IND. Regarding emergency admission cases, there was a case of alcoholic pancreatitis managed conservatively. Acute appendicitis cases were 2, which undergone open appendicectomy. Femoral hernia case was 1, which undergone hernia or raphe. Acute cholecystitis case was 5, which was managed conservatively, among which 3 were female and 2 were male patients. There was another head injury patient, which was also given conservative management. There were also minor operations done in the month of August in our unit, which was done in safety OTs and also in our emergency OTs. These include excision of sebaceous cysts, about 50 number of cases, including 8 male and 7 female. Nail extraction cases were there. We include a total number of 7 cases, including 4 male and 3 females. Incision and drainage cases were there. Number 2 male and 2 female. There were 2 cases of granuloma excision in females and 2 cases of canaccord injection, that is sclerotherapy, of 2 female patients. Regarding morbidity and mortality, we had 3 morbidity cases of 2 males and it was also a female. I have mistaken at the number. There were 3 morbidity cases related to wound gaping infection or some seroma discharges, and 2 mortality cases, which I'm highlighting in my following slides. The one mortality case was, this was an unknown female middle-aged patient, which was admitted with severe head injury. She has no valid documents with her and no accompanying person also. She was admitted in our female surgical ward, but she suddenly developed convulsions and then she became comatose and ultimately died. This patient was another patient with the carcinoma head of pancreas, which had palliative triple bypass surgery in our unit. Initially, then she develops initially, although it was stable but later she developed some medical complications like electrolyte disbalance. Her BP was also not remaining stable. She was developing shock-like features. She was shifted to CCU Then she was stabilized initially, and she was again brought later back to general ward. But then she again developed these types of electrolyte disbalance, septicemia, and finally she succumbed.
Itaman, as I told you, mortality cannot be given in 2 lines. You should give the patient background. What is the patient? What are the status? When is the surgery done? What happened immediate post-op? 1, 2. So go with the chronology. It's not that you just give 2 lines about the death patient. We like to see what happened to this patient, what treatment was offered, what happened afterwards, and what is the immediate cause of death. So for mortality, you should be little more vigilant to find the details about this patient. Okay. So these are 2 important. You see, the data is data. You're giving data, you're listening data. But
Okay, sir.
what we like to analyze and think about it is the morbidity and the mortality in the particular patient population. Okay. So these are more important. Any comment from anybody? Any comment?
Okay, sir. Okay.
Any comment?
Mahunda. Hello.
Yes, madam. Yes.
In the unit 3 description, I really could not understand what was Whipple's palliative operation. What was he meaning
No,
by
not
that?
Whipple's. Triple bypass.
He said
Not Whipple.
he said Whipple's
Then he said
palliative
bypass.
operation.
Good morning.
Yeah. So
No,
please.
I
Let's say
didn't mention
catheter.
So
Good morning,
it
ma'am.
Triple bypass.
Ma'am,
Hello?
the patient name is some Purkait Eldar someone, ma'am. She had
Pratima Mitra.
Pratima Mitra. She had a carcinoma head of pancreas. The tumor was encroaching upon the head of the pancreas, CBD, and it was obstructing stomach also, ma'am. The tumor was so huge, and she had a ascites. We did ascites tapping. The tapping didn't show malignant cells. We did explorative diagnostic laparoscopy first. It was showing a single liver mets. The patient is having CBD obstruction. It was so severe. Jaundice was around 19 and everything, and she was having gastric outlet obstruction also, man. The case is an inoperable case, but due to the palliative symptoms, we have been operating the case, man. The patient underwent a diagnostic laparoscopy. Then we found this. Then we decided to open it and do the triple bypass for the patient. We did triple bypass and we shifted the patient to CCU. The patient was in CCU.
Listen, doctor, my only objection was, was that you were saying it was a Whipple's palliative procedure. The palliative procedure is not in the name of Whipple's.
Yes, mistakenly done. It is triple bypass. We have did it.
Right. And in the second case also, where you said that you did in an obstructive jaundice patient with a choledocholithiasis, you people did a cholecystectomy, a choledochotomy, and a drainage operation. I would really like to know what drainage operation was done in that lady.
Ma'am, choledochotomy. We did open CBD exploration. Then the stone has been removed. Then we did a choledochotomy.
Okay, fine. Thank you. It was a good presentation, but keep out the points which sir was saying. And as when I was looking at the presentation, I had one thing in my mind to all the units was that when you are writing the number of OTs and all that, can you present that in a tabulated form? It looks nice, and you are able to also read it very well.
Okay, madam. We'll see it.
Right, sir. Mahunda, this was like when I just line or bullets instead of doing that.
Yeah. We'll try to change.
Yeah, right, sir. Thank you, sir. It was nice.
Thank you,
right. Thank you, sir.
Thank you.
Thank you, everybody.
Thank you.
Thank you, sir.